This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Well, this is a really interesting topic, and I'm schizophrenic on this, which will probably surprise some of you. But I wanted to go through this, and I'll try to make up some time because I apologize for going over on the first talk. Now, I have the Dennis Bandick paper on graft surveillance was written in 1986, which was the year I finished my fellowship. So when I got back in the Air Force, we got our first duplex scanner. They were only duplexing carotids, and we started duplexing all our vein grafts. And I think that it's pretty clear that for vein grafts, duplex surveillance makes a lot of sense. So over a period of time, people established, when we first started doing this, we had a black and white scanner. We did spot scans of the graft because I still do reverse vein grafts like Dr. Porter trained me to do. And it was hard to see the whole graft with the older scanners in black and white. So if we got several sites with normal velocities, we were pretty happy. But over time with color scanners, people developed criteria which are in general agreement with certain peak systolic velocity ratios and peak systolic velocities, you could predict which grafts were going to fail. And this was huge because for vein grafts, on clinical symptoms alone, you can't predict failure. Now, so then the natural question, which all of us are interested in, since therapy is switched from open bypass to endoluminal therapy, could you apply the same technology that we use for vein grafts? I mean, why shouldn't it work? You can see a stenosis. And the question is, though, what's the natural history of these lesions? Because you shouldn't treat a lesion just because it's there. So we treat vein graft lesions because we know which ones are going to cause vein graft failure, and vein graft failure is morbid. Not quite so clear for endovascular therapy. So this is an old example of a patient I treated in the Air Force, and that patient got a FemPop. Obviously would have got endovascular therapy now because it's a pretty short SFA lesion, but this was 20 years ago. And the lesion on angiogram with the arrow doesn't look so impressive, but this was the excised vein segment, very severe intimal hyperplasia in an otherwise good caliber vein graft. And that's what that same lesion looked like on histology, small lumen. So let's go back a little bit. Emmerich Szilagyi wrote a great paper in 1973, and duplex scanning pretty much supports everything he noted. So he had a large series of patients with vein grafts. The ones who were patent at hospital discharge all underwent serial arteriography, and a third of the grafts developed what he called intrinsic stenosis. And then he classified the lesions. Was it stenosis that looked fibrotic? Was it a valve site? Was it a suture line? Then he also saw other changes, intimal thickening, aneurysmal changes, and progressive atherosclerosis in the patients that were followed for long enough. But if you look at patients that had focal vein graft stenosis, or focal stenosis at a valve site, or anastomotic stenosis, most of those grafts went on to occlude if nothing was done. And that pretty much is held up. So the next concept that was important after Szilagyi's paper was Veith. In 1984, wrote this paper about the failing graft. So these were patients who came in with recurrent limb ischemia, were thought to have an occluded graft, but when they got angiograms, were found to actually have patent grafts that were threatened either by an inflow lesion, an outflow lesion, or a stenosis in the graft itself. So the problem with that approach is that you only identify about 20% of the patients that have a graft that's threatened. The other 80%, when they come in with a vein graft problem and have recurrent symptoms, their graft's actually occluded. So those two go together. So we basically, with color scanners, you can find high-grade stenoses. You can grade them based on velocity ratios. And basically, if you have a velocity ratio that's higher than 4, that's a significant graft stenosis. Almost all those grafts will fail if they're not treated. So what's the premises for vein graft surveillance? The premise is, which is true, that most failures in the first 3 to 5 years occur from, or first 1 to 3 years occur from intrinsic graft stenosis, that if you don't treat a high-grade stenosis, the graft will occlude, that it's often silent clinically and is detectable by duplex, and you can follow it by duplex, and that the vein conduit's precious. So if you lose that, no matter what you do to treat an occluded vein graft, it doesn't perform as well as if you'd kept the graft open. So those are the premises for vein graft surveillance. So then the controversy was, what do you do with intermediate vein graft stenosis? So we actually showed in a pretty large series that if you had an intermediate stenosis, so you developed a lesion with a peak systolic velocity between 200 and 300, intermediate vein velocity ratio of 2 to 4, you could watch those patients, and actually about a third of them resolved. Only 3% occluded without some progression, and then about 2/3 progressed, and when they progressed, we fixed them. So that's that. Now, what do we know about endovascular therapy? So I'm going to focus mostly on the SFA because it's really hard to get restenosis rates on tibial angioplasty. So what are the factors that we know increase the risk of failure? Probably lesion length, although there's some debate about that with the advent of subintimal angioplasty. Task classification, definitely higher restenosis rates for task D lesions and probably C. Runoff is really important. There's numerous studies that show if you have worse runoff with an endovascular therapy, that your therapy doesn't work as well. Diabetes, in general, if you have an occlusion versus a stenosis, and also CLI patients versus claudicants. So this is a group of papers that just point out, on the right there is all the factors that have been identified. These are all SFA stent series. These are the different factors I just alluded to that influence restenosis. So what do we know? Well, restenosis after endoluminal therapy is probably more common than after vein grafts. Most of these stenoses are silent, so shouldn't we do something to try to prevent them from causing failure? So this is a really good paper. Jap Booth group wrote this, but basically there's only 2 or 3 papers in the literature that actually did surveillance of endovascular therapy and looked at the natural history of it. Most series have focused on developing criteria for stenosis and assumed that the same algorithm we use for vein grafts should be applied to endovascular therapy. Well, in Europe, they take a different view of things. So basically, they did ABIs, duplex, and clinical exam, and they watched the patients to see what happened. They did not do any prophylactic interventions. So what happened? 52 patients in their series, so 42% developed restenosis. And duplex was pretty good at predicting it, but so was ABI in this series. And if they had used duplex surveillance as a criteria for reintervention, they only would have prevented 1 actual failure. So they concluded it wasn't effective. So we still do surveillance of our endovascular procedures. This just got published in 2012. I'm going to run through parts of this study. So again, the question was, you can do this. You can do the same thing we do with vein grafts. You can see stenoses develop. But does prophylactic intervention make a difference? And our bias was that we were not going to treat the patients unless if they were a CLI patient and their wound stalled or they got recurrent breast pain or ulcers, we would treat them. And if their claudication got worse, if they were a claudicant, we'd treat them. But otherwise, we would just watch them, which I was told by some people was unethical, but I didn't think it was unethical because you're trying to treat a patient, not a lesion, right? So the purpose of this study was to determine how often you got restenosis after endovascular therapy and what happened to these patients when they got it. So it was 100, these were just SFA patients. We threw out people with multi-level disease and people with tibial disease, which is most of what we treat actually, but just to make it cleaner. And basically, patients got prospective surveillance with the same protocol that we use for vein grafts. And we defined stenoses in the same way. So basically, if the velocity was less than 200 and the ratio was less than 2, we call that normal. If they were 2 to 300 in velocity ratio here, that was a moderate stenosis, and then here was severe. So what happened to those patients? So this is the algorithm that we followed. And basically, if the first scan was normal, they got one at 3 months, and if that was normal, they got one every 6 months for 2 years. We didn't do prophylactic repairs except for 2 patients because the attending got nervous. So what happened? What was failure? Well, failure was if the occluded segment actually, if the treated segment actually occluded, or if they got recurrent or persistent symptoms. So our general policy was just to watch the patients regardless of the duplex results. Now, so what did we find? Well, all these patients got a scan within the first 4 weeks. And in 67% of patients, the scan was entirely normal. So there was no residual flow disturbance at the site. And if you followed those patients over time, they had a very low occlusion rate. So actually, if they have a normal early scan, that predicts a really good outcome. If they had an abnormal early scan, how did that play out? Well, a small number, 7 of them had severe stenoses on the first scan. And this was kind of interesting, actually, because some of them got better. I mean, 4 of them actually got completely better and went away, and 4 went on to occlusion. And same thing, now moderate stenosis was interesting. This had a different natural history. It was less predictable. So about half the patients, they stayed stable, a small number progressed to severe, and only a small number went away. Now, so this is the distribution of the patients based on their most recent scans, so after they got follow-up. If they started out normal and stayed that way, only one of them occluded. So if they had serial normal surveillance studies, you were very unlikely to get an occlusion. But if they had a moderately abnormal scan, actually 9 of them eventually ended up occluding. And in the severe group, though, it was much less. Some of the patients, most of the patients actually with a severe flow disturbance after an angioplasty didn't end up in occlusion. So it seems to be different than vein grafts. And so if you look at the sensitivity, specificity, and positive predictive value, if you had decided to intervene on the severe stenoses, the positive predictive value was only 4%. It was miserable. So this study showed us that about 2/3 of the patients had totally normal scans, which actually was quite similar to what we had found with vein graft over many years. There was a higher incidence of de novo stenosis, meaning that the early scan was normal, but the patient then got a restenosis in 3 to 6 months. This was 5 times as high in the endovascular group as the vein graft group, but the progression was much less predictable. Now, so our conclusion from that study was that the natural history of restenosis is different in endovascular therapy compared to vein grafts, that they're more likely to develop a de novo stenosis after endovascular therapy, but at least using our current protocol, we couldn't predict which patients were going to go on to have trouble. And actually, only one of the patients in that whole group occluded and came in with severe limb ischemia, and that was saved with a bypass. Now, that's most of these, well, it was a mixed group. So the problem with those patients was they had atherectomies, they had angioplasties, they had stents. The question was, what about stents? So we published this in JVS with 109 consecutive SFA stents between the U and the VA, and we looked at patients with stent failures. So 33 of those patients, so almost a third, failed over time, 8 of whom came in with acute limb ischemia. And that was the reason we got interested in this study, because we had 2 patients with covered stents that came in. So what happens with stents? Well, these basically, we looked at covered stents versus bare stents. These were pretty long lesions, so the covered stent patients had 25 centimeter long lesions. Even the bare nitinol stent patients had 14 centimeter lesions. And we found that if you had a covered stent, you were more likely to present with grade 2 ischemia when you came in. What happened to the runoff? This is a key question. So when endovascular therapy fails, it doesn't go back to ground zero. So if we looked at the patients who developed an occlusion or a restenosis and then got re-imaged, so that wasn't every patient. So you might have a patient with a restenosis whose symptoms weren't bad and decided they didn't want to do anything. And you might have a patient who occluded and said, you know, my leg's kind of like it was, let's just see how I do. Anyway, of those patients that we evaluated, 35% had deterioration of runoff scores. So we had 2 people in this study that examined every angiogram and graded the runoff score using the SVS runoff score. And the average amount of blood vessel loss amounted to about 1 runoff vessel per stent failure, whether that was open stents or covered stents. So a quarter of the patients that came in with stent failure actually came in with severe ischemia, including 4 claudicants. That seems slightly more likely if they had a covered stent. And when they did fail, so this doesn't apply, we don't know what happened to the patients whose stents stayed open and were doing okay, but if they failed, they came in with worse runoff. So my conclusion from all this is we really don't know. I think for vein grafts, it's pretty clear that duplex surveillance is beneficial because we can find these stenoses, we can grade their progression, and the natural history of those lesions seems pretty clear. The moderate ones can be followed more closely. About half of them progress. They get treated before graft occlusion, but they don't usually suddenly occlude. The high-grade stenoses almost always result in graft failure. Prosthetic grafts, ultrasound's never been shown to be of benefit. For PTA, I think that those failures are usually due to restenosis, and those patients usually get symptomatic first, and that you can't predict the progression based on the duplex. So angioplasty patients, I'm pretty comfortable just following clinically. Stents, I think, may be different. I think when you get stent restenosis, you can usually get them open. We've got pretty broad experience with that, but you've lost runoff, and when you look at reintervention for stent failure, the results aren't very good. So I think stents may be different, but I still don't think we know which stents need reintervention. So thank you very much.
So as you can tell from my title, I'm going to be a little provocative. And among the many things that have changed about the practice of vascular surgery over the last 10 to 20 years, I would suggest that one of them is that we have approached a point where we are now treating restenosis almost as much as native atherosclerosis. This is kind of a watershed that occurred to me when I started looking at some data. And I'll show you some of that data, and I think you'll see that that's true. The question is why and what can we do about it? The other thing I would point out, we're going to hear about healthcare reform shortly. What's the game changer? If I was to say to all of you, well, we're going to have to do fewer procedures that work better, that makes logical sense. But the game changer is that actually that's not how the economics has worked, but that's how it's probably going to work. So we need to start thinking twice, and we've heard this morning about the importance of selecting the right treatment for the right patient. It's going to become more important as we go forward in the era of healthcare reform. Everybody's familiar with this slide. It's been up here actually earlier today. The endovascular revolution hit us in vascular surgery in the 2000 era. In the last decade, we've seen that there's been a major shift in the treatment of peripheral occlusive disease, yet the increase in endovascular interventions has outpaced the decline in bypass surgery by more than 3 to 1. So that can only be a couple of conclusions from that. We've either shifted the threshold for treatment to treat patients who we weren't treating before, and or we're doing multiple treatments in the same limb, and I think it's likely that both of those are true. I think it's unlikely the disease has tripled in the last 10 years. And we know that associated with that, the costs have risen quite dramatically. This paper only looks at the national inpatient sample, which is just a 20% sampling. So don't focus on the absolute numbers of millions of dollars, because it's actually probably in billions with a B. But just look at the trends over time in the costs associated with the treatment of claudication, rest pain, particularly claudication. Over time, there's been a threefold increase in the use of angioplasty-like procedures over this interval. This is only the inpatient data, and we all know that a lot of these procedures are being done in the ambulatory setting, and look at the rise in costs over time. And the question I would ask you is, do the results really justify the enthusiasm that's being demonstrated by this market analysis? Here's what we know, and it was shown this morning pretty clearly. If we just look at 2 years, and 2 years is not a long time, particularly for a claudicant. Let's just talk about advanced task C&D femoropopliteal disease. How common is it that the things that we do don't last for 2 years? Well, I wish I could say it was different, but unfortunately it's not uncommon. If you look at just plain old balloon angioplasty, the 2-year patency rate is probably around 30%. If you look at the best or combined data for stenting, it could be anywhere between 30 and 60%. If you look at bypass, it's probably around 65 to 80%, depending on whether it's prosthetic or vein. No matter how you slice it, these are not rare occurrences, and every one of us who has a busy practice sees patients with treatment failure every single week. So this is a problem, and it remains our biggest challenge in our field. It's more severe in the infrainguinal circulation than it is in the larger vessels and in the carotid circulation. We have limited current strategies. We have heard this morning about some exciting new treatments, drug-eluting stents and balloons. We do have the first approved drug-eluting stent for the periphery this year. We'll see if it really lives up to the expectations as time goes on. But still, I would say today, restenosis remains the greatest unmet need in our field and for our patients. So the question I asked is, how can we actually tell the burden and the impact of restenosis as a disease? If you looked at restenosis as a disease, could you actually tell what's going on? There's actually very limited data on the true frequency and the effects of failed interventions, particularly in claudicants, where the outcomes of restenosis may not require treatment, but also in critical limb ischemia. And if you just look at reintervention and patency data, that really underestimates the impact on the patient. There are many patients with restenosis who don't get a reintervention or don't have an imaging study who are suffering recurrent symptoms. The question is the incidence of restenosis in our practices rising? And really, what is the effect of a failed treatment on subsequent outcomes for that patient? And I think these are questions that we really don't know the answers to, but I think we really need to get a handle on them. Many have advocated an endovascular first treatment approach because it was presumed that it's harmless if it fails. And you see on this slide, I don't know if you can see, there's a failed stent above this bypass, because you can always potentially do a bypass as long as there's a target that remains intact, as in this case. However, we're getting accumulating studies that have suggested that a bypass done following a failed previous intervention is not the same as a bypass done as a first procedure, and is in fact associated with poorer outcomes. We'll show a little bit of this data shortly. This is the basal trial. It's obviously a decade old. It's already been mentioned a little bit today that it's limited in terms of its application to current practice. Critical or severe limb ischemia patients were randomized to bypass versus endovascular first. And one of the secondary analyses was to look at actually the impact of the treatment received on amputation survival. And when they looked at a subset of patients who had, and compared the patients who got a bypass after a previous failure of angioplasty, compared to the group that had initial bypass, and admittedly this is not the way it was randomized, it's pretty clear that there was a dramatic difference. The patients who had a bypass done after their angioplasty failed did not do very well, and certainly didn't do as well as the patients who had a bypass first. And the authors concluded, among other things, that bypass surgery after failed angioplasty was significantly worse than bypass performed as the first revascularization attempt. The question is, which patients should get what first? But the point is that a bypass done as a salvage procedure is not really the same, even if the previous procedure was an endovascular procedure. This has now been confirmed in other studies, and I'll show you some more recent data. This is data from 2011. It was the first look in the vascular surgery group of Northern New England data at this question. They looked at 1,880 patients who had undergone lower extremity bypass purely for critical limb ischemia, and basically they showed that the impact of either a failed endovascular treatment on your left or a failed previous bypass on your right were equally bad predictors of the outcome of the next bypass. Said it in another way, we already knew that a redo bypass was not as good as a first-time bypass, but a bypass after failed endo seemed to be about as bad as a bypass after a failed previous bypass. And here's the concern. It's a concern that I have. If we apply this sort of broadly, is this what the results of bypass surgery are going to look like if it's only done after a previous intervention has failed? And I think that this is not the kind of outcome of bypass surgery that we had in the 1990s and 80s. And it could be because disease has changed, but I think it's also because we're treating patients farther down the road because they've gotten multiple endovascular procedures. The Vascular Study Group of New England has a robust now reporting arm. As many of you have heard, there's nearly 30 hospitals involved in this, and we took the opportunity to update that set of data that I just showed you to get more current information about the frequency of secondary procedures. So I will sit here and tell you that I do believe that restenosis is actually reaching an epidemic. So if we look here in the VSGNE database at, this is overall at more than 7,000 interventions, you can just look at the history of those who've had a previous bypass or a previous angioplasty, or either over just 10 years has essentially doubled in the practice of these vascular surgeons at 30 hospitals. So it's gone from 20% of their bypass cases to over 40%. Nearly 1 out of every 2 bypasses are being done because of a failed previous revascularization in the same leg. And if we circumscribe this a little bit better to only look at the first procedure done when the patient came into the registry, this is the index procedure. You could see in 2003, of the first procedures done in these hospitals for a leg bypass, about 22% of these were secondary, which means after a previous endo or previous bypass. And then if you looked going forward up to 2011, 2010, it's in the 40% range. So roughly a 70% relative increase in the practice of, in the surgical practice of peripheral artery disease has become secondary to previous treatment failures. Well, who cares if the results are okay? Well, it's very hard to compare the results because you really are comparing apples and oranges when you compare a secondary procedure to a primary procedure. So in order to compare these, we had to go through great pains to try to normalize or adjust the data. And you can see if you just look on the left-hand side, the primary bypass patients, 2350, the secondary ones, 1154. They differ according to a lot of characteristics at baseline, including age, smoking, medication status, and even graft anatomy. So, and a variety of other variables not shown on this slide. These were adjusted using a propensity approach to essentially normalize these across the 2 groups so that we could try to compare outcomes between the patients who had a secondary bypass versus a primary intervention. And if you looked at just the in-hospital outcome, secondary bypass is really no worse than a primary bypass in terms of the early events, meaning graft failure at discharge being only 2%, in-hospital major adverse cardiac events are low, in-hospital mortality is low, so there really isn't a safety concern with doing your bypass as a secondary procedure. But when you look at the long-term outcomes, and one of the points that you need to understand is that the VSG&E data only mandates follow-up at 1 year. So this is only 1 year follow-up, and you can see what's happening with the curves. First of all, they're significantly separating within 6 months, and the patients who've undergone secondary bypass, when we looked at their freedom from major reinterventions, ipsilateral amputation and mortality, and other major adverse limb events, you could see that even after adjustment, there's a significant worse outcome for patients who had undergone their bypass after a failed previous endo or bypass. And I can tell you, though not going through the data, that the data was equally distributed between previous endovascular and previous bypass, that as the impact was exactly the same. Furthermore, the impact was worse for the patients who had critical limb ischemia. Those secondary bypass results for critical limb ischemia were significantly more impacted than those done for claudication. And again, this did not matter whether the previous failed intervention was a bypass or surgery. And the other point I would make to you is if you could look at what's happening with these curves, I don't think it's hard to imagine what it's going to look like at 2 and 3 years. These curves are growing farther apart with time. So here summarized are the 1-year outcomes from this analysis, which was just presented at the Society for Clinical Vascular Surgery meeting a couple of weeks ago. It's been submitted for publication. Significantly worse limb-related outcomes between primary and secondary bypass at 1 year follow-up, suggesting that a bypass done after a failed intervention is not the same as a bypass done as the first procedure. Is that really a Nobel Prize-winning observation? Probably not, but you hear it over and over again, that it doesn't matter because we can always rescue this with a bypass. Well, it's not working out that way. So if this problem is big, and I would say to you that it is big, it's time for us to figure out who's getting it and what we can do about it. And I would suggest to you that despite how common we see this in our practice, we really don't understand this very well. In fact, all we use to predict restenosis for the most part are technical anatomic factors. But it's pretty clear that patients themselves, systemically, come to these procedures with different underlying risk factors, including perhaps things that they have in their genetic makeup and or how they're going to respond to the treatment at the time. Some of the data suggests that things like African American and minority race is a risk factor for restenosis, female gender, this may be anatomy. Diabetes is interesting. In the endovascular data, it looks like it's a risk factor for restenosis, but it doesn't predict vein bypass graft restenosis. Certain prothrombotic states and extreme dyslipidemias and smoking are all out there as risk factors. I think also there's some data that suggests, although it's not definitive, that inflammation and inflammatory markers may be important at predicting restenosis. And an important question that I think is out there is whether or not some people are simply predisposed, as they may be predisposed to keloid after scarring on their skin or other types of fibrotic problems. Are the people predisposed to react poorly or to heal poorly after our interventions? There is some data from other areas. There's not so much from vascular surgery or the periphery. There is some data from the coronary literature, and this paper caught our eye a couple of years ago. This is data from a Dutch study that looked at 2 large coronary stenting, bare metal stenting studies, and did some genetics. And they looked in particular at this gene, a single nucleotide polymorphism, which is a change in a single letter of the genetic code, a single letter of the genetic code, in a gene that has to do with cell growth, the P27 gene. And they actually found that this SNP, which is very common in a white population, there's a SNP, the AA variant, is present in about 20% of people. That variant was highly protective for restenosis in a bare metal stent model in the coronary. You can see how splayed these curves are. The patients with the AA variant had a 2 to 3-fold less risk of failure of their coronary stents compared to the other patients. And they actually tried to explain this in the laboratory by looking at the expression of the gene. Not confirmatory, but it suggests that the gene expression for this particular gene, which blocks cell growth, was linked to the AA genotype. So this kind of provocative paper prompted us to also look at the same exact polymorphism in a lower extremity bypass population. With our collaborators in Boston and in Seattle, we looked at a cohort of over 200 patients in whom we had blood samples and who we had detailed clinical follow-up over 3 years. And we did the same exact genotyping for the same exact marker and found essentially the same exact things. If you look at primary patency, again, you can see that out of those 205 patients, roughly 15 to 20% had the AA genotype, and their primary patency at both 1 and 3 years was statistically markedly higher than the patients with the other two P27 genotypes. This doesn't necessarily prove that this genotype is associated, because there are many gene studies that have not been validated, but it certainly suggests that it's likely to be important. And if you looked in a Kaplan-Meier fashion, you can see that the patients with the AA versus the CA and CC did very different. Again, this just suggests to me, if nothing else, that it's not all anatomy, that some people are programmed differently to behave to intervention, and we need to understand this a lot better. And we then took this into a multivariate model controlling for lots of other factors, including critical limb ischemia, age, diabetes, and after all of that adjustment, having that AA P27 genotype was 2.5-fold protective for primary patency after adjustment for other risk factors. So that leads me to finish up with where we're going now. Where we're going now is we need a much better understanding of the factors that predict the healing response following vascular interventions. And we've now begun, with the support of the Vascular Cures Research Foundation, to launch a large prospective cohort study to try to describe better the risk factors and the markers for restenosis in the peripheral circulation, both in terms of being able to better predict, but hopefully also this will help us identify new treatment targets for prevention of restenosis. This study will incorporate both an SFA stenting and a vein bypass surgery arm. Patients are being recruited and are getting blood draws at baseline and at 2 points after their procedure for genomics, protein biomarkers, as well as lipidomics. The clinical follow-up is over 2 years. The study was just started 3 months ago and is now rolling out to 3 centers and will roll out over the next couple of years. And hopefully, a couple of years from now, we'll have a lot more information to talk to you about why we can maybe better predict and identify ways to address this problem. So in conclusion, restenosis, in fact, is endemic in our current vascular practice. And despite that, little is known about patient-specific risk factors beyond technical considerations. And in this era of increasing endovascular intervention, the incidence of restenosis and its impact on the surgical treatment of peripheral arterial disease appear to be increasing substantially. Treatment failures, as you've already heard, negatively impact the outcomes of secondary procedures. There is no free lunch, no matter what we do. Downstream effects, therefore, should be carefully considered in selecting a primary revascularization strategy. And ultimately, we need better treatment selection algorithms to improve patient outcomes and to reduce the overall burden of PAD care. And ultimately, this is going to require level 1 evidence based on accurate disease stratification. Thanks very much.